have to move on for the next speaker. And as Dr. Madi mentioned that kidney is one of the organs which is affected by the other organs and affecting the other organs. So it is an interaction between the kidney and the other vital organs. That's why you are focusing in the first day about one of these syndromes. It is the hepatorenal syndrome. And Dr. Shams Abdelraheem is one of the eminent speakers with us tonight. He's going to cover this topic. Dr. Shams is a critical care consultant in Manchester University hospitals. And Dr. Shams is graduated from Cairo University. He got his master's degree in critical care from Cairo University. He got a European Diploma of Intensive Care Medicine, MRCP, and postgraduate certificate in medical education. And Dr. Shams is completed his training in UK. He has a special interest in ventilation and medical education. So I'm delighted today to have Dr. Shams with us on board. Dr. Shams, the mic is yours.
Thank you very much, everyone. Thank you, Dr. Madi, for the brilliant talk. Unfortunately, mine will not be as brilliant as yours. So forgive me, everyone, if I'm not up to your expectations. First of all, I don't have any conflict of interest to declare. And today, as we said, that we'll be talking about hepatorenal syndrome. Please let me know at any point if the voice is not clear or if the screen sharing is interrupted. So first of all, hepatorenal syndrome, relevant to the critical care point, is it too relevant or is it not very relevant? That depends on which hospital you work in, what other specialties that you work with, or what other facilities that your hospital can provide. Because in some of the units, critical care consultants or critical care doctors may not see any hepatorenal syndrome at all. In other hospitals, they will see hepatorenal syndrome more frequently if there is a liver unit or not. So today we'll be talking about the pathophysiology of the hepatorenal syndrome. Before we go to the definition and diagnostic criteria, we need to understand what is that syndrome first, because as we heard in the first topic, it's acute kidney injury is not a single syndrome. It can be different types of syndrome, and one of them is the hepatorenal, and we need to understand what's happening in hepatorenal to start with diagnosis and management, or initiating the management of the syndrome. So without really understanding what's the pathophysiology of the hepatorenal syndrome, as the name implies, we will treat every renal impairment in hepatic or in chronic liver disease, we'll treat it as hepatorenal syndrome, which is not true. So pathophysiology definition and then management. The main step in the pathophysiology of the hepatorenal syndrome is that there's renal vasoconstriction in the context of splanchnic vasodilatation. And this is the most significant essential step in the development of the hepatorenal syndrome. So let's have a look and see our patient who has chronic liver disease, alcoholic liver disease, liver cirrhosis, hepatitis, whatever the chronic liver disease the patient is having, and might be acute as well. But the patient started to develop advanced stage of liver disease, and subsequently it started to have portal hypertension. Now, because of the arrangement of the liver, there will be some degree of ischemia, and most of the organs, with the exception of the lung, react to ischemia by releasing vasodilators. So the liver, similar to most of the organs, will release vasodilators, which include nitric oxide or prostaglandins. So when the liver releases the vasodilators, that will reach the heart, and the heart will start to work as in high cardiac output state. So they will increase the heart rate, the heart will increase the cardiac output, aiming to improve the splanchnic circulation. So that will be splanchnic vasodilatation, secondary to the nitric oxide and prostaglandin. And what we mean with this splanchnic circulation is celiac, superomesenteric, and inferomesenteric arteries, which are branches of the aorta. Now, that sounds great because more blood will reach the liver and the ischemia will be reversed. But unfortunately, that doesn't happen. So the liver actually doesn't respond nicely to this splanchnic vasodilatation. And what happens in this situation, that because of this splanchnic vasodilatation, the patient will start to develop ascites. If not already, the patient has ascites when we started the process of portal hypertension. What about the kidney? We said there is interaction between the kidney and the liver and any other organ in our body. So while the blood is shifted to splanchnic circulation, the kidney will start suffering from hypoperfusion. The blood is not equally going to the kidney in the same amount that's going to the liver via the splanchnic. So the blood will drop in the kidney. And how is that affecting the glomeruli? So we have afferent and efferent glomeruli. In the afferent, the blood pressure will start to drop. As a response to drop in blood pressure, the kidney will sense that as in, well, we don't have enough blood, the effective blood volume has dropped, so we need to retain some water, we need to improve the blood pressure, so we need to retain some salt as well, and sodium. And that will be by activating the renin-angiotensin-aldosterone system. So by activating the renin-angiotensin-aldosterone system, there will be a couple of effects. First, because we started to retain water and sodium, the ascites will get worse. Most probably it will start to go into a vicious circle, and the effect of the angiotensin will cause vasoconstriction. Unfortunately, the effect of the vasoconstrictor effect of angiotensin will worsen the hypoperfusion of the kidney. While it's meant to improve the splanchnic vasodilatation or reverse it, it doesn't. So the effect of the renin-angiotensin-aldosterone system, which is meant to be reversal of the vasodilatation and improving the perfusion to the kidney, actually make it worse. So the hypoperfusion of the kidney will be worse, and without any improvement of the splanchnic vasodilatation. As a sequence of that, ascites will be worse. Splanchnic vasodilatation will continue in the presence of nitric oxide and prostaglandin. Hypoperfusion of the kidney will continue to be worse. More in an angiotensin-aldosterone system, more vasoconstriction, more ascites, more hypoperfusion, and a vicious circle will continue. So to summarize, we started with portal hypertension, advanced liver cirrhosis or advanced liver disease, a bit of ascites, and then vasodilators shifted the blood to the splanchnic area and caused hypoperfusion of the kidney. And that activates the renin-aldosterone system, causing vasoconstriction and more hypoperfusion. And then the cycle will continue on and on and on. So this is essential to understand and differentiate from other causes of acute kidney injury, whether in the context of chronic kidney disease or without chronic kidney disease, with chronic liver disease or without chronic liver disease, how a hepatorenal syndrome develops. As we said, it can happen mainly in chronic liver disease patients. Usually it will happen in cirrhosis and ascites. And in fact, 20% of patients with cirrhosis and ascites will develop hepatorenal syndrome at 1 year, and 40% will develop hepatorenal syndrome at 5 years. Portal hypertension, also patients with portal hypertension can develop hepatorenal syndrome. And very important that the patients with tumor sometimes can develop hepatorenal syndrome, liver tumors. Advanced liver disease, whether that's because of alcoholic liver disease or because of fatty infiltration or some of the other autoimmune liver disease, they still, if they develop portal hypertension and develop ascites, they may still go through the same process of cirrhosis and ascites, developing hepatorenal syndrome, whether that is post-hepatitis or for any other reason, they still can develop. Having said that, primary sclerosing cholangitis are relatively uh, protected from developing hepatorenal syndrome. But hepatorenal syndrome doesn't happen only in chronic patients. It does happen in acute patients and fulminant liver failure as well. And in fact, 25 to 30% of patients with fulminant liver failure can develop hepatorenal syndrome. Now, very important question, is every acute kidney injury in the context of chronic liver disease a hepatorenal syndrome? And that's why we started at the beginning with the pathophysiology, because the answer for that is no, it's not. Acute kidney injury can happen in the context of chronic liver disease or chronic liver impairment for various reasons. Sepsis. The patient with sepsis can develop acute kidney injury. Is that necessary hepatorenal syndrome? Not necessarily hepatorenal syndrome, because the pathophysiology might be different when they develop the acute kidney injury. Still, as we heard in the first presentation, that the outcome is not great anyway, but in chronic liver disease, sepsis can be the cause of acute kidney injury. Similarly, pre-renal because of overdiuresis or because of GI bleeds, so liver cirrhosis, and then esophageal varices, and then started to develop bleeding, gastrointestinal bleeding. They can have very low blood pressure, and the low blood pressure will cause pre-renal acute kidney injury. And in this case, administration of blood and other blood products, stopping the bleeding, reversing the coagulopathy, may reverse the process of acute kidney injury. Similarly, nephrotoxic drugs, acute tuberous necrosis, vasculitis, it can happen in acute kidney injury. And there are some links between hepatitis and certain types of glomerulonephritis, which we need to exclude first before we say this is a hepatorenal syndrome. And equally important is obstructive renal disease or obstructive uropathy. It can cause acute kidney injury. So it's not straightforward. Every acute kidney injury in chronic liver disease means a hepatorenal syndrome. Now, as we understand what is hepatorenal syndrome, what happens in the physiology, pathophysiology of the disease, where it can happen, and let's have a look and see how to diagnose this. And most important to say about it, it's a diagnosis of exclusion. Now, there are definitions of hepatorenal syndrome. These definitions changed over time. And as we heard in the first presentation, the definition of acute kidney injury has changed over time from ATN and acute cortical necrosis to the Reifel criteria to KDIGO criteria, and all of this has an impact or had an impact on the definition of hepatorenal syndrome. So previously, when you used to say we have two types of hepatorenal syndrome, type 1 and type 2, now the definition has changed to say it's hepatorenal syndrome, AKI, and I'm sure that all of you now remember the triangle, what is AKI, and of course, the type 2 will be non-AKI, which was further divided into AKD and CKD. Now you know from the first presentation, 3 months or more than 3 months, that will be the cutoff value between the AKD and CKD. So if we look at the definition of the hepatorenal syndrome, the old name of type 1 hepatorenal syndrome, this will be the criteria that we will rely on to diagnose the hepatorenal syndrome. The old name used to say in type 1 that there is an increase in creatinine concentration to 2.5 milligram per deciliter within 2 weeks. So first, 2 weeks, and second, 2.5 milligram per deciliter. So that's absolute value of increase of serum creatinine plus no response to diuretics, giving 2 liters of fluid daily, albumin 1 gram per kilogram per day, the presence of cirrhosis with ascites. You need to rule out the presence of shock. So if there is any shock, you need to reverse the shock itself and then exclude any other causes. So no current use of or recent use of nephrotoxic drugs, and no signs of structural kidney injury. So we need to rule out whether that's glomerulonephritis or post-renal obstruction. So normal findings on renal ultrasound, absence of hematuria, and absence of proteinuria. So that was the old name of the hepatorenal syndrome, or the old definition of hepatorenal syndrome type 1. And if any of the criteria doesn't apply here, it's type 2 hepatorenal syndrome. So renal impairment in the context of chronic liver disease, when you rule out all of these factors in the patient having cirrhosis of ascites, that will be type 1. And if these criteria doesn't apply, that will be type 2. The new definition, which is made to be more compliant with the KDIGO criteria, this part of the definition is exactly the same. So no response to diuretic withdrawal, IV fluids, volume expansion, giving the albumin, presence of cirrhosis and ascites, absence of shock, nephrotoxic drugs, and all structural kidney disease are exactly the same in the new name. The only thing that is changed in the new definition is that the type 1 doubling of serum creatinine 2.5 over 2 weeks has changed to a serum creatinine of more than, increase in serum creatinine. It's an absolute increase in serum creatinine of more than 0.3 milligram per deciliter within 48 hours, or 1.5 times increase in the baseline creatinine value within the previous 3 months. If you don't have any previous value in the last 3 months, you just need to use the most recent value and see if there is 1.5 increase from the baseline creatinine. So instead of using the 2.5 as a cutoff value for defining hepatorenal syndrome or acute kidney injury, now we're using an absolute increase of 0.3 milligram per deciliter or 1.5 increase. Very important to say about the definition of acute kidney injury, hepatorenal syndrome, acute kidney injury, is that it uses an intervention in the definition. So before you say, and that's why we said it's diagnosis of exclusion, before you say this is hepatorenal syndrome, you need to stop diuretics, you need to reverse the shock, you need to give albumin, you need to give volume expansion. Once you've done this and you see no response to all of these, this is where you start saying this is actually hepatorenal syndrome, acute kidney injury. In contrast, type 2 now has changed to hepatorenal syndrome, non-acute kidney injury, which is divided into 2 groups: the hepatorenal syndrome acute kidney disease, if the deterioration in the renal filtration or glomerular filtration rate happens in less than 3 months, or it's CKD when this happens over a period of more than 3 months. So if you compare type 1 versus type 2, or HRS AKI versus HRS non-AKI, you will find out that hepatorenal syndrome AKI happens more acutely over a very short time, and in fact the outcome is worse in hepatorenal syndrome AKI compared to non-AKI, which takes a bit longer time and the outcome is slightly better. So what precipitates hepatorenal syndrome, whether that's type 1, type 2, AKI or non-AKI? Many things can precipitate hepatorenal syndrome, but on the background, you need to know that this patient have chronic liver disease, and on top of this, there is ascites and portal hypertension. Infection can cause acute kidney injury, but infection in the same time can worsen the process of the vasodilatation and portal hypertension and can cause more vasoconstriction of the kidney so that they can precipitate HRS. And even if you try to treat them with antibiotics alone, you will find that many of the infection that can happen doesn't necessarily, treating the infection doesn't necessarily improve the hepatorenal syndrome. Very confusing, it sounds. In practice, it's really difficult to distinguish between AKI that is caused by sepsis or it's AKI secondary to hepatorenal syndrome that is worsened by infection. It's very tricky to distinguish between two entities if they do exist as two entities. In fact, GI bleeding, again, they can worsen the process of the hepatorenal syndrome, the pathophysiology of the hepatorenal syndrome. But in the same time, GI bleeding can cause pre-renal hypovolemia and then acute kidney injury. Again, how to distinguish when you start treating the pre-renal, when you start to replenish the intravascular volume, and when you reverse the shock stage of the GI bleeding, and once this is reversed and you still cannot find any improvement in the renal function, may say at this stage, well, I think it's hepatorenal syndrome because you've done your part in ruling out shock or excluding shock and treating the pre-renal stage. Spontaneous bacterial peritonitis, again, they can commonly occur in the context of hepatorenal syndrome. So when someone is already developing hepatorenal syndrome, they can have spontaneous bacterial peritonitis, but actually spontaneous bacterial peritonitis can worsen the process and the pathophysiology of hepatorenal syndrome. Are diuretics involved in the process of developing hepatorenal syndrome? Possibly, yes, but not necessarily every single patient having diuretics will develop hepatorenal syndrome. And in fact, the main reason why we should stop the diuretics is that we make sure that the effective intravascular volume is well repleted. So when you start the diuretics, you replenish the intravascular volume, do the expansion, you may find that the process has reversed. But if that doesn't reverse, was it the diuretics that caused the hepatorenal syndrome? Most probably, diuretics do not cause hepatorenal syndrome in themselves. It's usually secondary to the process of vasodilatation that we talked about. And commonly, diuretics will be used in high doses in diuretic-resistant ascites, which, by coincidence, these are the group of patients that will develop hepatorenal syndrome. Chronic kidney disease, again, so the patients with chronic kidney disease are more expected to develop acute kidney injury and hepatorenal syndrome in the context of chronic liver disease. So again, we need to rule out any other worsening in the renal function. So let's say a patient with diabetic nephropathy who is worsening from the diabetic nephropathy point of view, we need to rule out that this is caused by the poorly controlled diabetes or by nephrotoxic drugs or by any other mechanism that is worsening the chronic kidney disease before we say this is a hepatorenal syndrome. But in the same time, they are more liable to have hepatorenal syndrome. Now, what can happen in chronic liver disease and acute kidney injury? As we said at the beginning, is every acute kidney injury in chronic liver disease caused by hepatorenal syndrome? The answer is not. Sepsis is responsible for 46% of AKI in chronic liver disease. Pre-renal, 32%, and actually hepatorenal syndrome is responsible for only 13% of cases of AKI in chronic liver disease. And other causes are responsible for 9%, other causes like glomerulonephritis. Now, we mentioned the serum creatinine value to diagnose hepatorenal syndrome, and there is a problem in hepatorenal syndrome being diagnosed in chronic liver disease using the serum creatinine. Couple of them are, a couple of the issues are that creatinine, the production by the liver is impaired in chronic liver disease. So the conversion of creatine to creatinine doesn't happen in chronic liver disease as expected. So despite the fact that the patient may not having good filtration, the creatinine may remain low. And as we know, in chronic liver disease, the muscle mass decreases, and that means that the creatinine production will be subsequently reduced. It depends on what type of assay they use to assess the serum creatinine, but the high bilirubin, especially if significantly high, will give you inaccurate measurement of the creatinine assay if you use the calorimetric creatinine assay. So as we heard, we can use a number of other alternatives. We can use nystatin C, which is another marker of renal function, another marker of renal assessment. We can use NGAL. So there are other markers of the renal physiology that we can use alternatively to have more accurate measurement of the renal function. Now, most important part, which will be related to our work after understanding what's happening, is how to manage hepatorenal syndrome. First and foremost, the most important step is treatment of the underlying liver disease. Without reversal of the liver pathology or of the liver failure, the process of hepatorenal syndrome will continue to worsen until the renal function completely dies, and eventually the mortality will be high. And treatment of the underlying liver disease can be in different ways, but let's say if someone is alcoholic liver disease, liver can remarkably improve after abstinence from alcohol. So if you stop alcohol, if someone stops alcohol for more than 6 months, most probably the liver function will start to recover partially, and eventually this patient might improve the liver function, and the hepatorenal syndrome pathology may slow down. Equally important, these patients will be more, when they abstain from alcohol, they will be more likely to be accepted for liver transplantation. And if you reverse the process by liver transplantation, the patient can improve eventually. Hepatitis B, again, if the patient with hepatitis B start treatment with antiviral, they actually may improve the liver failure, and there is some improvement in the liver function that can slow down the process of hepatorenal syndrome. So this will be the first step of the management of hepatorenal syndrome, to focus on the liver itself and try to reverse the pathology. Compared to the GI bleed, compared to the nephrotoxic drugs, compared to the pre-renal, this doesn't happen. When you try to treat the pre-renal cause of AKI, you give the fluids, you give the replenish the intravascular volume, but the liver function may not necessarily affect the AKI. Here in hepatorenal syndrome, the liver function does affect, because as we've seen in the pathophysiology, it's vasodilatation that's driving the whole process of hepatorenal syndrome. Now, the risk factors management for hepatorenal syndrome, if you start to see that the patient is developing hepatorenal syndrome, you need to stop the nephrotoxic drugs, as we've seen in the definition, stop the diuretics for 2 days, and reassess the intravascular volume. If there is any ongoing infection that may worsen the process, treat the infection with antibiotics. And then volume expansion. And as we talked about the volume expansion, it's in the definition of the hepatorenal syndrome that you need to treat first. And when you fail to treat or to reverse the hepatorenal syndrome or acute kidney injury, this is when you diagnose hepatorenal syndrome. And you need to rule out other causes of acute kidney injury. So these are the risk factors that we need to mitigate first before we move on to the saying, well, actually, this is hepatorenal syndrome, and we need to start treating it as a hepatorenal syndrome. The lines that are listed here are human albumin solution, albumin, vasoconstrictors, TIPS, transjugular intrahepatic portosystemic shunt, renal replacement therapy, and liver transplantation. And we'll go through them very quickly. So first is albumin. And as we've seen in the definition, we need to give albumin by 1 gram per kilogram per day. So for example, if you have a patient with 60 kilograms, you need to give 3 bottles of 100 ml of albumin 20% per day. So 20% and 20 means 20 grams and 100 ml. So you need 60 of 60 grams. That's 3 bottles of 100 ml every day. And some of the hospital can give 5% or 4.5%, and that means that you will need 4 times the volume. Unfortunately, the bottles themselves, they come as usually 500 mils, so you will need to give more volume, and that also helps with the volume expansion. If you're thinking about giving the albumin and at the same time giving the IV fluids, maybe 5% would be a good option here. In addition to volume expansion, albumin and volume expansion are noted to improve mortality in hepatorenal syndrome or to reverse the hepatorenal syndrome. However, this is the first step of the management. You stop the nephrotoxic, you stop the, you treat the shock, you give the volume expansion, and you give the albumin, and then you see the response after 48 hours of the initial step of the management. It's usually not used alone. So we have other options, and the option next will be the vasoconstrictors. Now, which type of vasoconstrictor is used depends on where are you managing this patient. And chronic liver disease patients commonly will be treated on a medical ward unless they need more intensive care support, or this is the policy of your hospital that they're developing now, 2 organ failures. So they need to come to the ICU for closer management or invasive lines or arterial blood pressure management. So it depends on where these patients are managed. In my hospital, these patients are managed in the ward, even when developing hepatorenal syndrome. We continue to treat them on the ward. So the options we have, we can give terlipressin or noradrenaline. And terlipressin is a vasopressin analog. And what's different between terlipressin and noradrenaline is that terlipressin works more on the splanchnic circulation. And it sounds odd that we have a process where vasoconstriction is implicated in the worsening of the renal function, and the treatment is actually vasoconstrictor. But here the vasoconstrictors are directed to the splanchnic area mainly, because we want to reverse the process of the nitric oxide and prostaglandin caused vasodilatation. If you reverse that, you will improve the systemic vascular resistance, you will increase blood pressure, you will increase the perfusion to the kidneys, and then you will stop secretion of the renin angiotensin aldosterone system, and that will start to reverse the pathology of the hepatorenal syndrome. Hence the use of vasoconstrictors. Terlipressin has side effects, which generally ischemia, can be ischemic bowels or ischemic hearts, angina, or peripheral ischemia. And when given with volume expansion, giving vasoconstrictor and volume at the same time, that can cause pulmonary edema, abdominal pain and diarrhea, or other side effects of terlipressin. And it's given as 1 milligram IV every 4 to 6 hours, a maximum 12 milligram per day. Can be given by peripheral cannula, so that can be done on a medical ward, and you don't need to admit the patient to a monitored bed to the ICU to give terlipressin. When compared to noradrenaline, they had similar results. Noradrenaline and terlipressin, there was no difference in mortality, but more side effects were noted from the use of terlipressin. However, the noradrenaline use means that you need to bring the patient to the ICU, you need to put a central line, invasive monitoring. So on balance, you need to weigh the benefits and adverse events that you may expect from using terlipressin or noradrenaline. Again, for an intensivist, especially these days when the non-COVID patients struggle to find a bed in the ICU, it might be worth just trying to terlipressin on the ward with outreach team from the ICU, going every now and then to see what's happening with the patient and being under the radar of the ICU. It doesn't necessarily, having hepatorenal syndrome doesn't necessarily mean bring them to the ICU and put lines and starting norepinephrine, because terlipressin may do the job. Having said that, terlipressin is more expensive than noradrenaline, and obviously the noradrenaline is cheaper than terlipressin because it's been on the market for a very long time. Terlipressin and albumin combination are superior to terlipressin alone or albumin alone. So most of the studies that compare the use of terlipressin versus the use of terlipressin and albumin, or the use of albumin versus the use of terlipressin and albumin, found that the combination is better than single therapy. Alternatively, if we don't use terlipressin or noradrenaline, we have vasopressin IV, or I think in the United States, terlipressin is not available, so you can use midodrine and octreotide. Octreotide is somatostatin analog, and midodrine is sympathomimetic, so it's alpha agonist. So again, they cause vasoconstriction, and they reduce the portal hypertension, and hopefully that will start to reverse the hepatorenal syndrome, or this is the theory. So we said we'll try to reverse whatever happening in the liver. We'll give antiviral for the hepatitis. We'll stop drinking. We'll ask the patient to stop drinking. We'll reverse whatever happening with the acute liver failure, if that was fulminant liver failure secondary to toxicity and the patient needs transplantation, we'll send the patient for transplantation. Meanwhile, we'll give the albumin, we'll give volume expansion, and we'll give vasoconstrictors, and then we'll wait for the response. What if we don't see any response from these measures? Well, TIPS is an option. It can be used from the start before we reach the point of hepatorenal syndrome to minimize the chance of developing the hepatorenal syndrome itself. So as a preventive measure, if you do the TIPS, the TIPS is actually a shunt. You go from the internal jugular vein to one of the hepatic veins, and then through the hepatic vein, you make portosystemic shunt, and that will reduce the blood pressure in the splanchnic or the portal system. And eventually that should reduce the vasoconstrictor process that's causing the renal hypoperfusion. But in treatment of hepatorenal syndrome, TIPS is not necessarily successful. So you can use it before you reach the point of hepatorenal syndrome. But once the patient is in hepatorenal syndrome, there is no strong evidence that TIPS will improve hepatorenal syndrome. So if this is not an option, you can go further and provide renal replacement therapy, which most probably in this case would be continuous renal replacement therapy rather than intermittent hemodialysis. And that means ICU admission. Who should receive renal replacement therapy compared to, generally speaking, AKI and renal replacement therapy, EL versus late? Here, the situation is slightly different because the short term of mortality of cirrhosis and AKI is 90% if the patient is not a candidate for liver transplant. So again, liver cirrhosis, developing AKI, and if the patient is not a candidate for liver transplant, the mortality is 90%. So the first step before we say we need to consider renal replacement therapy or not, we need to consider transplant or not. Is the patient candidate for transplant or any other intervention, or the patient is candidate for TIPS? If not, it's very unlikely that providing renal replacement therapy will improve the overall outcome in these patients. So the recommendations is that renal replacement therapy should be reserved if the patient is a candidate for transplant. And the next question will be, is the patient candidate of, when the patient is candidate for liver transplant after providing renal replacement therapy, will bridge to transplant, will bridge to TIPS, and then the patient is accepted by liver transplant center. Is there any chance that the renal will recover from a hepatorenal syndrome? The answer is not clear. Again, similar to acute kidney injury and other syndromes, the patient may recover the renal function and may not. And this is very important in what expectations we will tell the family after the referral to the liver transplant. And that takes us to the discussion with the family, which is usually very difficult to go through all of this with the family. Hepatorenal syndrome, liver failure, been already struggling with the liver disease, but very clearly the outcome is guarded, the outcome is poor. And the key thing is that we prevent the process of hepatorenal syndrome. So a couple of things that we can do is to give albumin in spontaneous bacterial peritonitis even before developing hepatorenal syndrome, or give norfloxacin, which is shown to reduce the incidence of hepatorenal syndrome when the patient is developing spontaneous bacterial peritonitis. But the outcome usually relies on reversal of the liver failure in the first place. And without recovery of the liver failure, the likely outcome is death within weeks. So as a summary for hepatorenal syndrome, I hope that I touched base on all aspects of hepatorenal syndrome very quickly. Hepatorenal syndrome is acute kidney injury in the context of liver impairment. The main pathology or main pathophysiology of that is planchenic vasodilatation and renal vasoconstriction. The prognosis from hepatorenal syndrome is poor without liver failure reversal, whether that is medical reversal or transplant reversal. Hepatorenal syndrome is a diagnosis of exclusion, so we need to rule out other differentials. The medical treatment of hepatorenal syndrome include reversal of precipitating factors, volume expansion, albumin, and vasoconstrictors. And as a bridging, we can use TIPS, a renal replacement therapy, aiming that we will reach the point of liver transplant. And the question to admit or not to admit to the ICU should be based and assessed individually for every single patient, whether escalation to the ICU is appropriate or the patient can be managed on the ward with some support from the critical care line. Any questions at all?
Thank you, Dr. Shams. Very simplified and targeted. I think I have one question only for you here. Dr. Sawi is asking, is dopamine effective as vasoconstrictor in hepatorenal syndrome? He's asking.
As far as I'm aware, I haven't seen any studies using dopamine for hepatorenal syndrome as vasoconstrictor. I know that it might be completely different topic talking about dopamine and the renal dose of dopamine. The vasoconstrictors that are used commonly in hepatorenal syndrome are norepinephrine, terlipressin, or vasopressin. You can use dopamine as a vasoconstrictor, I guess, in general, if you don't have any of these options. But whether there is evidence to support that, I don't think so.
Perfect. Thank you. Any other questions? I think no more questions for you, Dr. Shams, in the chat box or Q and answer. Okay. Thank you, Dr. Shams.
Thank you very much.
We can move on.
I think there's someone on non-steroidals long-term for pain relief. What percent can develop hepatorenal syndrome? But are you talking about interstitial nephritis caused by non-steroidals, or are we actually talking about the chance of developing hepatorenal syndrome? Because if you understand, this is Hilal Siddiqui, if you understand the pathology of hepatorenal syndrome, we stop the nephrotoxic drug to avoid worsening of the condition, or to avoid the chances that this is related to interstitial nephritis, for example, using non-steroidals. But it doesn't lead to hepatorenal syndrome. I hope that's clear enough.
Thank you. Thank you, Dr. Shams.